Well, thank you very much. It's an honor to be here and share a little bit about what's going on in the MS field with regards to biologic therapies. First, here are my disclosures. What is MS? Just briefly, it's a chronic inflammatory disorder of the brain and the spinal cord. It's manifest here on gross examination where there is demyelination. Loss of myelin as well as axons. It's most notable in the white matter, but we've come to find there is dramatic demyelination and axonal transection in the gray matter as well. It's not just a white matter disease anymore, but it's a white and gray matter disease. We can appreciate it much easier in our patients using MRI than gross pathology. Patients are very appreciative of that. We can see that here. Man, it's late in the afternoon, isn't it? One can see here on the FLAIR images and the post-gadolinium images the lesions that we see in our patients. We can measure these lesions over time, and this becomes a key outcome metric for phase 2 clinical trials of new anti-inflammatory therapies in MS. And I'll be showing you a little bit of the data from some of our biologic therapies, which look not just at clinical, but also these MRI findings. We try to prevent new lesions on FLAIR images and also try to prevent gadolinium-enhancing lesions that are seen on the bottom set of images. This is what we think is going on pathologically in terms of severed axons. It's either acutely during the acute inflammatory injury or a chronically denuded axon over time will eventually become transected because it doesn't have the nurturing support of the surrounding myelin, and then it retracts back to its nerve cell and eventually dies. This occurs in the white matter, but also within the gray matter. There is a lot of neuritic transections. And we've come to appreciate over time, and particularly the last 10 years, that the injury of MS is in the relapsing early stages, not just in the later progressive stages. That is shown here, a schematic of how we approach MS, how we think of MS. First, clinical manifestations. Each of those EKG-looking pulses are clinical relapses, optic neuritis, transverse myelitis, brainstem syndrome that patients will recover from or sometimes incompletely recover from. And eventually, after about 5, 10, 15 years, typically patients will transform into a gradually, little by little, progressive form of the disease. They may have some superimposed clinical relapses, but by and large have this gradual insidious progression regardless of whether there's ongoing inflammation. When we look at MRI, we see new lesions on the MRI even before they manifest their first relapse, if they happen to have an MRI before clinical manifestations. And then later on, as they transform into progressive disease, they tend not to have so many lesions over time. There's gradually progressive brain atrophy over the entire course. We think the acute inflammation early on sets up an accelerated degeneration later on. We don't really know what's driving the progressive phase, but what we do know is that our anti-inflammatory therapies don't work too well. As a result, we have, as of last month, our 10th FDA-approved therapy for relapsing MS. 12 billion may be an underestimate. This may be up to 13, 14 billion a year by this point. This is based on 2011 numbers. In contrast, in secondary progressive MS, we have no therapies with demonstrated efficacy. And so this is the huge unmet need of the MS field. We've basically cured the relapsing remitting stage of the disease, and we have made absolutely no inroads in altering the course of disease in the secondary progressive. And this also applies to the primary progressive patients who skip the relapses and go right into progressive MS, and this is the huge unmet need. So we have, these are the 4 top biologic therapies that are either approved or in late stage development. There are a number of other biologic therapies that are in earlier stages of disease. Because of the limitation on time, I didn't know I had the extra 8 minutes. I'm just going to focus on the first 3 of these, but briefly mention that rituximab showed very positive results in a phase 2 trial, and its more humanized version, ocrelizumab, although abandoned for rheumatoid arthritis and other rheumatologic conditions, is continuing development for relapsing MS and is in the midst of phase 3 trials. But we don't have results of that, although I expect they to be similarly positive as the phase 2 results for both ocrelizumab and rituximab. So that's all I will share about rituximab. Let me dive in about natalizumab. And that is our only FDA-approved biologic therapy, and it targets adhesion molecules. So the way lymphocytes leave the bloodstream and go into the brain, they have to stick to an activated endothelial cell surface, and it does that in the brain endothelial system through VLA4. And if one uses a monoclonal antibody, that blocks that adhesion. If you don't adhere, you can't diabetes through the blood-brain barrier and into the brain tissue, and you can prevent the inflammatory cells from entering the brain. I won't show you the efficacy data. That's very old, over 10 years old, but it is a highly effective therapy, decreasing new lesions by about 95%. And probably the difference between that last 5% between 95 and 100% reduction in new lesions on MRI are the patients who develop neutralizing antibodies to natalizumab. Obviously, if you block the ability of the antibody to block the adhesion molecule, you block its efficacy. So this is our most highly effective therapy. And if a patient is having active inflammation, as long as they don't develop neutralizing antibodies to the therapy, almost all patients, we can stop their inflammation quite robustly, quite quickly with this therapy. So the main concern we have is with PML. I'm sure you've heard enough about PML with other diseases at this point. Let me tell you a little bit about the update of experience we have with PML and natalizumab in MS. As of April 2nd of this year, so don't say you don't have contemporary data at this conference. This is very up-to-date data. As of April of this year, 347 confirmed cases of natalizumab-related PML. That's among 112,000 patients exposed. As of December, when this report was issued, they didn't have the total number of patients exposed, but nonetheless, it gives us a rough ballpark of how many patients have been exposed. This gives us a rate of 3.1 per 1,000 natalizumab-treated patients. Now, this total number of cases, it's sort of the death toll. It's not that helpful. What we really need to know is what is the incidence. So the incidence, as you can see here, 4.81 per 1,000 of patients in Europe and 2.03 per 1,000 of patients in the US. So about a twofold increase risk in the EU. We'll get back to that in a moment as to why that is. Interestingly, about 6% of the cases were asymptomatic. So these are patients who received routine MRI screening for surveillance of their MS and perhaps PML, were found to have new lesions, underwent a spinal tap, found to be positive for JC virus PCR, diagnosed as having PML, albeit asymptomatic, and then were treated accordingly. The overall outcome, very different than what we see in other conditions like lymphoproliferative disorders and HIV. The survival rate, 76%. Which is quite high. We have a very aggressive monitoring and diagnosis, and we have the ability with this disease to do plasmapheresis, remove natalizumab, which is the inducing agent of PML, and we can, within a couple days, completely rectify the immune deviation that caused PML. And so that's one of the benefits of using this therapy, unlike, say, rituximab, where although rituximab may be gone, you're not bringing the B cells back really quickly. We can completely restore the immune deviation within a couple days, several courses of plasmapheresis, and we can completely remove natalizumab, make the receptors available. They can now transmigrate across the blood-brain barrier and attack the JC virus. Interestingly, those asymptomatic patients, 100% survival. So when we can catch it early and can intervene, these patients do relatively well. Now, don't be misled. 100% survival, it doesn't mean 100% without impairment. These patients were left with, at least many of them, with some impairment or quite a bit of impairment, but they at least survived. So looking at the breakdown of the incidence, this is as of April 2013, one can get a sense that at least initially during the first couple years of therapy, there is a gradually increasing risk with duration of exposure. This sort of way of counting of number of the patients over 12 infusions or other patients over 24 infusions really lumps all the later patients in together. So this is not as helpful of a number to look at. It also changes over time. I'll show you that in a moment. What's a little bit better is to look at the individual epochs. So patients who are at 1 to 12 infusions, what is the incidence of PML? Patients who are at 13 to 24 infusions, 25 to 36, and that is shown here. And one can see much more dramatically that there is an increased risk or increased incidence of PML with duration of exposure. And that's become one of our risk factors in stratifying patients' risk of developing PML. And interestingly, we don't quite know why, but that risk seems to plateau after about 24 to 36 months. So it doesn't continue going up as they stay on it longer and longer and longer, but it does seem to plateau up at some sort of basal rate once they get to about 3 years of exposure. Now, this has changed a little bit over time. This is showing you the incidence according to treatment duration in February of 2010 versus April of 2013. I realize this is a little bit small, but in patients over 18 months in 2010, the incidence was 1.5, and now in 2013, the incidence is 4.55. So the incidence changes because you're looking at all the patients further on are impacting that risk. Much more stable way to look at it is here by treatment epoch, and one can see that in the 13 to 24 months, the incidence is staying roughly the same at about 1.5. So this is probably a much better way for us to be looking at the incidence of PML, but again, one can see over the course of time, there is an increased risk. We're also wondering, do I just touch here? Yes. We were also thinking that, well, what's going on here? Is that truly a decreased incidence over time? And what you can see, as we got more data, it stabilized, and we see it's pretty much of a plateau at that point. If we follow the incidence over time, the actual estimates, we see the estimates for some of the epochs have changed, and some of the epochs have not. So at the bottom of the screen, which is 1 to 12 infusions, there's a very stable, very low incidence. But for reasons we don't understand, 37 to 48 infusions, there's been a gradually increased incidence over time. We expect with the development of the JC virus serologic test, which I'll get to in a moment, that the patients on this drug will be enriched for seronegative patients, and the frequency of PML will go down. So we anticipate in the next 6 to 12 months, this graph will take an inflection and will start going down significantly, not because of a change in the disease or a change in the therapy, but a change of the patients we have that are remaining on this disease. So what do we know about the patients who have developed PML on natalizumab? The duration of natalizumab therapy, it varies widely. We have patients with very little exposure and some with a lot of exposure. Prior treatment, 42% of the patients who developed PML had prior chemotherapy for their MS. 25% had mitoxantrone, and the remainder a variety of things, including cyclophosphamide. In comparison, looking at populations of MS patients, only 12 to 20% of all natalizumab-treated patients have received chemotherapy prior to natalizumab. So there appears to be an enrichment of patients getting PML who had prior chemotherapy relative to the overall population. In the TIGRIS study, which is a natural history study of patients on natalizumab, we see 13% in the US and 24% in the EU had prior chemotherapy prior to going on natalizumab, yet we see the 42% of patients who develop PML having had prior chemotherapy. So it does appear that prior immunosuppressant therapy increases the PML risk by about 2 to 4-fold. And that explains the increased rate in Europe because the European neurologists have used chemotherapy in their MS patients quite a bit more than the US neurologist. Gadolinium enhancement, very common at presentation. HIV and some other presentations of PML, gadolinium enhancement is quite rare. The majority of MS patients who present with PML have gadolinium enhancement. Symptoms, cognitive, motor, language, visual symptoms are quite common. Also, things we don't think about in MS, seizures and paroxysmal events, they are not uncommon either at presentation with PML. So there's a wide variety of presentations that patients can come with that become PML. About half of patients have very low viral loads in their CSF, and this is an important thing to recognize. A viral load, half of patients have a viral load under 500 copies. So one needs to use a very sensitive PCR test Focus Lab has an ultra-sensitive JC virus PCR. Gene Major at the NIH is happy to do CSF testing on patients with possible PML. The important lesson here is a negative JC virus PCR isn't always negative. And if one has a brain MRI that looks highly suspicious for PML, don't accept just a negative CSF for JC virus PCR. One, make sure it was an ultrasensitive assay that was run, and two, consider repeating the assay in a week or two to see if it's become positive. And then finally, plasma exchange is considered standard treatment for natalizumab-related PML. It was shown in a study several years ago to accelerate the removal of drug and to accelerate receptor desaturation and accelerate lymphocyte transmigration across an in vitro blood-brain barrier. And it accelerates all of that by about 90 days. So you can get a patient's immune reconstitution going about 90 days faster than just allowing the normal attrition rate of natalizumab and its binding to the receptor. So where does that leave us with our patients? Risk stratifying has become the key for PML, and there are three clearly defined factors that predict the risk of PML. JC virus antibody status, so do they have serology that positive that's in their blood for JC virus? Have they been exposed? About half of patients, half of MS patients have been exposed to JC virus as measured by this test. About half of them have not. Prior chemotherapy and treatment duration. And using this table, which is updated from what my colleague and I published a couple years ago, shows you that in some patients the risk of PML is 1 in 45,000. In other patients the risk is 1 in 50. So clearly this is a dramatically different therapy for different patients. And the risk-benefit trade-off is going to be extraordinarily different in one patient than it is for another. And it's not just an easy, is it something we use in MS? It depends on the patient. So to summarize natalizumab, the risk of PML has increased a little bit over the last couple of years. It's now about 3 in 1,000 overall. It does increase with cumulative exposure, but plateaus thereafter. The incidence will likely decrease now that we are taking JC virus seropositive patients and pulling them off of natalizumab and putting them on alternative therapies, thereby enriching the patient population on therapy for JC virus seronegative patients, which will then decrease the incidence. So there are 3 established risk factors: the JC virus seropositivity, previous immunosuppression, the duration of treatment over 2 years. There are 2 additional risk factors. One I've listed here, which has just come out this year, which is body weight. So there is some developing evidence now that low body weight is a risk factor for developing PML. Probably the mechanism is that the drug supersaturates the receptors, and the receptors stay saturated a little bit longer in the thin patients. So it used to be you can't have too much money or be too thin, and maybe in this therapy you can be a little bit too thin. And so there are some clinicians who, in the patients who are under about 100 kilograms, I'm sorry, under 70 kilograms, are spacing out their dosing interval to every 6 weeks in hopes that that decreases the risk of PML. I would only recommend doing this in patients, or consider doing this in patients who are JC virus seropositive. If they're JC virus seronegative, as long as they stay negative over time, and these patients are getting routine testing for JC virus every 6 months, currently FDA recommendations, as long as they stay negative, we think that the risk for PML is extraordinarily low. The other thing, which is just emerging now, will be presented later this month at the Consortium of MS Centers, is that the optical density, or what will actually be called the index for the positivity of the JC virus serology, appears to also be a risk factor. So in patients who test positive for JC virus in their blood, that is by serology in their blood, the half of patients who have been exposed to JC virus in the past, if they have a low index on that positive test versus if they have a high index, impacts their risk of PML. And it appears to impact it very significantly. An index of 0.9, you don't need to remember the 0.9, but that's just where they put the cutoff. Patients who were tested seropositive but an index below 0.9 had a 24% fold decreased risk of PML than patients who tested with a 0.9 or higher index. So even if you have the virus, one can stratify who's at lower risk for PML versus who's at higher risk. So we're probably going to end up having 3 strata: patients with negligible risk because they're JC virus seronegative, patients who are at low risk because they're seropositive but their index is very low, and patients who appear to be at much elevated risk. So this will be an emerging, will be a continually evolving issue as we go on. So our standard of care, we are now doing JC virus serology in all patients who are on natalizumab. We are doing it at the start of therapy and every 6 months in patients who are seronegative. We are also starting to do it at the time of MS diagnosis, just so we know, are they positive or are they negative? So as we go forward in the treatment algorithm, we know, is natalizumab a good option for this patient eventually, or is natalizumab not so good of an option? Granted, at diagnosis, if they're seronegative, they might convert to seropositive later on in time, and we'll have to recheck it if we really want to use natalizumab. But getting that status at diagnosis helps us understand as we start moving forward with that patient what therapies we might consider. There is finally an FDA request from the manufacturer to change the official labeling to allow it to be formally designated as a first-line treatment option in patients who are JC virus seronegative. I think that's mostly a marketing thing so that they can market it as a potential first line, but also to get neurologists to think, hey, in a patient who's very aggressive, this is a reasonable therapy to think about. So let me shift. Alemtuzumab and natalizumab, don't worry about the time. They will not take me as long as the natalizumab PML story. Alemtuzumab, currently in phase 3 trials, not clinically available for MS at this point. It is a humanized monoclonal antibody targeting CD52, cell surface antigen. This is, as best as people can tell, a rather anonymous surface protein expressed by T cells, B cells, monocytes, and eosinophils. Anonymous meaning we're just not smart enough to know what it does. Probably it does something, we just don't know exactly what that is. This monoclonal antibody produces a rapid, profound, and prolonged lymphocyte depletion, and it's followed by quite a distinctive pattern of cell repopulation over time. It's approved for CLL at this point, but was withdrawn voluntarily from the market by the manufacturer, mostly because the dosing regimen would not have been financially viable for the company to carry forward into MS. So they withdrew it from the market. Mainly, they wouldn't have made enough money on the MS patients per patient to justify taking it forward. So they pulled it off the market, but it is still available on a compassionate use for free from the manufacturer. So anyone who has a CLL patient who wants to use this drug can get the drug from the manufacturer by a special request. There have been 2 phase 3 clinical trials in relapsed and remitting MS. Both of these were compared to a standard injectable therapy, subcutaneous interferon beta-1a, or the Rebif preparation. There was the CARE-MS1 and the CARE-MS2. They were very similar studies, but one was treatment-naive patients, and the other was previously treated with other MS therapy patients. So let me show you just a little bit about what this drug does on a pharmacokinetic, pharmacodynamic basis. It rapidly and selectively depletes lymphocytes after each treatment course. This is showing after 2 annual treatment courses. In black is the profound lymphocyte depletion. So you can see neutrophils, monocytes, eosinophils, basophils, they're not really affected much. Maybe a little bit the neutrophils, but not a whole lot. This is really a lymphocyte depleting therapy. And the other white blood cells are really not affected much at all. Importantly, after alemtuzumab treatment, the CD19 B cells repopulate earlier than the CD4 T cells. And as shown here, this is the B cells repopulating by about 3 months after therapy, but the CD8 cells, and particularly the CD4 cells, are taking a much longer time to repopulate. So even the lymphocyte repopulation is different. And it's thought that these B cells coming back before the T cells come back is what leads to the uneducated B cells and the humoral autoimmunity that is seen with this therapy in MS patients and in other settings as well. Briefly, this is the outline of one of the phase 3 trials where patients were randomized either alemtuzumab for 5 daily courses and then at year 2, 3 daily courses compared to interferon given 3 times a week. There was also a 24 milligram IV group, which was later dropped over the course of the study when safety concerns were raised. This is its clinical efficacy. I'm going to show you just one slide about that. 55% rate reduction in the annualized relapse rate. So quite a marked reduction, somewhere between our current injectable and oral therapies and natalizumab. This isn't quite natalizumab level efficacy, but certainly better than our injectable therapies and probably a bit better than our oral therapies, fingolimod and dimethyl fumarate. So this outlines the efficacy on the other outcomes, the annualized relapse rate, sustained progression of disability, gadolinium enhancement, and new T2 lesions, and also reduction in progression of brain atrophy. So on a broad basis, no matter how you measure it, it is quite an effective therapy. So what are the safety concerns we have to worry about? And this is where the hiccup comes in with this drug. There is an increased rate of thyroid disorders, 18% in Alemtuzumab compared to 6% in interferon. Hyperthyroidism most common, mostly mild to moderate in severity, 1% with serious Alemtuzumab-associated thyroid events, including ophthalmopathy and thyrotoxicosis. This is detected through, there are also incidental findings of thyroid papillary carcinoma in 2 patients on thyroid screening. One had a known nodule prior to treatment, so does it increase the risk of thyroid carcinoma? That's a question. Most of these events were managed by conventional oral medicine. So the thyroid thing, not so much of a concern. This is showing you the incidence and the severity between the 2 treatment groups. A little bit more concerning is ITP. So ITP is seen in the Alemtuzumab, some laboratory diagnosed ITP based on the platelet definition with interferon, but not defined as serious adverse events by the investigator. So indicating that the ones with Alemtuzumab were the real ITPs that we worry about. These are identified through routine monitoring. Patients can notice increased bleeding as well. None of these patients needed a splenectomy. Education is an important aspect that's needed for patients being treated with this. But as you can see, 3 out of 376, about a 1% incidence of ITP. So putting that together, this is from the CARE-MS2, the second of the phase 3 trials, and one can see again an elevated rate of thyroid adverse events, serious thyroid adverse events, and ITP. So seen in both of these studies. To summarize, it's a cell surface antibody, profound lymphocyte depletion, clear efficacy in relapsing MS, perhaps somewhere between our current oral therapies and natalizumab, although we don't have the head-to-head studies with the current oral therapies. Humoral autoimmunity, main safety concern, thyroid, ITP, I haven't mentioned but has been seen, glomerular basement membrane disease as well. So one can also see good pastures with this. Basically, any B-cell aberrant humoral autoimmunity can be seen with this therapy because the B cells are coming back before the T cells have a chance to educate them. So its potential placement in the MS treatment paradigm not yet clearly identified because of these uncommon, I wouldn't call them super rare, 1% ITP is not rare, adverse events. So where this fits in to our current therapies, we're still trying to figure out. This is under review by the FDA, and a risk map will be the key focus. Finally, natalizumab, just a couple slides, anti-IL-2 therapy. This is even earlier in development, blocks IL-2 binding and its subsequent signaling, inhibits T and B cell activation, down-modulates the receptor. This has been approved in renal allograft rejection and is currently marketed as Zenapax. It's also studied in a wide variety of other immune-mediated diseases. This is basically how it works. It just binds the alpha subunit and then blocks its efficacy. I'm going to skip over this, but to show it has a very rapid and profound reduction in the IL-2 staining lymphocytes. So it was studied. It's in a phase 3 trial, which was just reported last week in Lancet. This is showing you the highlights of it. Quite effective, 50% reduction in relapse rate, quite profound reduction in sustained progression of disability and MRI measures. But again, we're back to safety. 2% incidence of serious infections versus none in the placebo group, single cases including autoimmune thyroiditis, Crohn's disease, hypersensitivity, lymphadenopathy. Importantly, a 1.4% incidence of serious cutaneous events. These are rash, atopic dermatitis, allergic dermatitis, exfoliative dermatitis, erythema nodosum, a lot of kind of rashy things, probably a lot of different names because neurologists really don't know the difference between these things. Importantly, there was one death in a patient with a serious rash. It's a patient who had a psoas abscess that then spread, became septic, and unfortunately died from the psoas abscess, probably somehow related to the serious rash. So quite effective therapy, but has some serious safety concerns. So its potential treatment, its potential placement in the MS treatment paradigm, not clearly defined yet, not because of the efficacy questions, it's clearly an effective drug, but because of these, again, not super rare, I wouldn't say common, but frequent enough that we have to think about it and worry about it. This has not yet been submitted to the FDA. So in summary, biologic therapies used in MS target various aspects of the immune response: cell ablation, cell trafficking, cytokine response. Efficacy varies between very good to excellent, so they are quite effective therapies, although there are various safety concerns. The actual safety concerns are dependent upon the therapy. Each have serious risks. Strong safety of the current oral therapies presents a challenge for understanding exactly where these biologic therapies fit into our algorithm. Neutralizing antibodies can develop. I haven't talked much about them, but at least with some therapies, particularly natalizumab, completely abrogate the effect of the therapy. So I will stop there and turn it back over.